Okay, so we finished up. What did we talk about last time? GI. We finished up GI. Any questions from any of that material there? Okay. Are you guys able to see it okay with the lights on, with the dark background, with the white text? You guys are fine with that? Okay, I just want to double check. I don't want to relitigate the whole lights on versus off debacle. I'm not doing it. No, I'm not gonna put that kind of stress on El Jefe over there. I don't know if that's a gendered term or not. Anyway, barely know English. So anyways, we're moving on, talking about pain management. I kind of put this under the guise of like orthopedics, but there's not a whole lot of like actual medications when it comes to orthopedics specifically to that. But there's a lot of pain associated with it, and there are a lot of meds that we're going to cover in that regard. Is anyone going to FAPA next? Not this weekend, but next weekend. Anyone? Any show of hands? No? If any of you have the faculties to make it to the coveted Sunday morning at 8 a.m. position time slot, I will be giving a talk there, actually on some of this stuff, actually about opioid prescribing for PAs, especially with some of the laws that have changed recently and all of that. I just finished it last night, and I do think it's going to be pretty good. I'm a little biased, but if you like the stuff here, you will like the stuff at that presentation. I'll probably also do like a dry run and record it and put it up after FAPA. So if you guys can't make it, I understand. I'll probably post it up at some point. Anyway, just a brief aside. I was working yesterday. I work today too, but I was working yesterday at the hospital, and I was delinquent in getting my N95 mask fitting done for the year. Anyone know what N95 masks do? Yeah, there's that filter. Basically, you don't breathe in a bunch of TB and cooties and stuff like that, right? Very important when you're working in the pharmacy, secluded from everyone else in the hospital, right? Anyway, but in case I do get out to the ICUs or the ED or wherever, it is very important. So anyway, so I was doing it in this, went down to employee health, and this little old lady was there. She's a nurse practitioner, and she was doing like the Hep B screenings and stuff like that. She was doing blood draws and all that. And she was coming up, she's like, "Oh, what are you here for?" And I was like, "Oh, I'm here for my mask fitting." She's like, "Oh, okay." And, you know, very little lady. She's at the end of her career, but very cute. And so she basically got on the topic like, "Oh, what do you do?" And I was like, "Oh, I'm in the pharmacy, but also I mainly teach full time." She's like, "Oh, what do you teach?" And I was like, "Oh, I teach at Nova Southeastern, their PA program." She's like, "Oh, I like PAs better." I was like, "Oh, that's very sweet, but yeah, I like nurse practitioners too, because you know my family's chock full of nurses, CRNAs, nurse practitioners." She's like, "No, PAs are better." And I was like, "Oh, that's very sweet." So, I figured you guys would like that anecdote. Anywho, so moving in to talking about pain management, something you probably need after taking some of my courses, right? Actually, we already talked about the antidepressants. We got that down. So pain is inherently very difficult to manage in people. Why do you think that is? Subjective. Okay. So when I say subjective, why is pain subjective? It's not quantifiable. Well, come on. I can put it on a pain scale. I can say my pain's a 10 out of 10 right now. Everyone's different, right? Everyone's a bit of a snowflake, right? Not in a derogatory sense, but everyone's a little different. Someone's 4 might be another person's 10, vice versa. And so you're absolutely right. It's a very subjective sort of thing. If someone says they're in pain, it's a very easy way to tell if they're actually in pain. Not really. Right? What are some objective things you could look at? Facial expression can be one thing. What if someone's like been dealing with pain for like the past like 10 years? They say they're an 8 out of 10, but they're just sitting there just kind of quietly reserved to their pain. They may not be actively grimacing, right? May not be a good sign of that. Could be good if you just had your leg broken. You're probably going to be showing some facial expressions that kind of pretty consistent with that sort of pain. What other things could you look at? Heart rate, blood pressure, right? Those typically are elevated when you're having acute pain. But again, a lot of stuff gets missed when you go to more the chronic side of things, right? So again, there's kind of this this modality where you're going to be focusing on the acute pain side of things, but also there's this idea of chronic pain, right? And so things tend to differ a little bit. You're going to find that chronic pain is managed much differently than acute pain. We'll kind of cover the medications that are going to be used for both of those and how their use is going to change a little bit, right? So anyway, it's very, very common, right? We know people are most often presenting to clinics and ERs and things like that for pain, whether it be abdominal, whether it be unspecified, whether it be after an injury, whatever the case may be. A lot of people are presenting for pain, and typically what do they want you to do for that pain? Make it go away, and how are they going to do that? Give me some meds, right? I need my meds. Give me something for this pain. And so again, that's why I focus on the meds here. However, it's very, very important to focus on the fact that we need a multimodal approach to pain. When I say multimodal, what does that mean? different modalities, right? So again, medications can be a very important piece of the puzzle, but it's not the only piece, right? You have to figure in things like, occupational therapy, physical therapy. You have to factor in things like what type of pain is it? Is it neuropathic? Is it somatic? The management is going to differ greatly between that. And so when it gets down to it, we're going to focus not on, and actually one of the big pushes nowadays is a move from looking at more subjective measures of pain, things like a pain scale, moving more towards functional assessments of pain. What do you think could be some functional assessments of pain? Or pain management, I should say. How effective is your pain management? Well, look at the functional goal, right? Is the person able to get out of bed and walk around, right? Is the person able to go back to work? Are they able to do the things that they like to do? Looking at these functional things that are very objective, whether the person can get in or out of bed or not, is a very objective sort of thing. You can clearly see that. And so by moving more towards functional goals, and again, one of the big things here is to make sure people retain function or give them back function. You'll see that's going to be one of the big pushes here, right? Because again, pain is subjective. If you can figure out a way to quantify pain, you'll be a billionaire, right? Because again, this is a very difficult thing to do and would help out a whole lot of clinicians. Anyway, what do you think are some barriers to people getting effective pain management? So let's look at it, say, from the patient side of things. What do you think? Stigma. So again, you think, oh man, if I get those nasty opioids, what's going to happen? I'm going to get addicted. I'm going to turn into a junkie. I'm going to be injecting myself with heroin at some point. Some people do that. Not a lot, but some people do. So there's sort of a negative stigma associated with that. There's some people who say, you know what, I'm not going to do it. I'm not going to take any pain meds. I'm going to tough this out. I'm going to be a superhero. I don't care if I'm trying to push a human being out of my body. I don't need any pain meds. More power to them, right? But a lot of people do need pain meds. Okay. They're worried about adverse effects. We'll cover some of the common ones. We'll cover some of the uncommon ones. But there's a lot of stigmas associated with that. Some people are very hesitant to receive pain meds, and that can be a big barrier to them getting good pain management. How about related to healthcare providers? What do you think? Okay, yeah, so there's not a whole lot of people who have specialized training in pain management, right? Again, just like you wouldn't walk into a neurosurgery office your first day after graduation and be like, all right, I know what's going on, I know everything, I'm a very competent practitioner. Can you walk into a pain management clinic and expect to do the same thing? No, you need specialized training, which may not be available. There's definitely not enough pain management practitioners out there. But and again, we try to teach towards the PCP kind of role, the general practice kind of role. Are you still expected to do pain management? For a lot of patients, yeah, absolutely, right. So you need to be aware of it, right? You may not be, having that specialized training, but you're still going to be expected to do it. So that can be one of the big issues there. You ever, and again, some of you have some ER experience, but you have someone who's coming in, they're complaining of pain. You've seen them there, a week ago. They're asking for their pain meds. They're saying, "Oh, I'm allergic to everything except for Dilaudid." What do you think? They're seeking medications, right? You think they don't have legitimate pain. Is that always the case? No. Is there a good way to tell if that's the case or not? Oftentimes, no, right? There's some things that I'll talk about that can kind of help us with that process, but there's a lot of provider cynicism that goes along with that, right? If the nurse walks in and says, "Hey, let's triage a patient," they're a pain seeker, they're an addict. You're immediately already clouded. Your judgment's already clouded because you have a preconceived notion of what that person is, right? And so it's important to make sure you kind of separate yourself from that and make sure you go in, having a open mind with every patient. But other things, there's lack of governmental regulation. There could be a lack of funding for things like PT and OT and other non-pharmacologic methods of pain management. So there's a lot of barriers here, right? Again, I may sound a little cynical because I always use sayings like, "How can you tell if a patient's lying?" Their lips are moving, right? That's an inherently cynical sort of thing that I say, but it is pertinent to things like toxicology, right? It may not be pertinent to all of your pain patients you deal with, right? You always say things like, when you ask a patient how much they drink, what do you do with that number? You double it, right? What do you do with their methadone dose? You half it, because people lie, right? People can tell you incorrect things in order to get things that they actually want, right? Or to portray themselves as a certain way. But again, you have to make sure you don't say cynical, right? You guys are very young. You have no preconceived notions. You're going to never be a cynical provider. It's all crotchety and doesn't ever give pain meds out, right? You guys, some of you might do that. I don't know, but that's the goal, to try to prevent that sort of thing. And again, could be lack of access, could be lack of medication availability, right? The right type of medications or the right type of therapies available, and so that can be a big issue as well. So anyway, as we mentioned, pain's pretty subjective. There's a lot of variation in the intensity. The pain, you assess someone's pain at 9 o'clock in the morning could be very different than what it is at 9 o'clock at night. Could be related to the activity they're undergoing, could be related to a number of different features there. And again, ultimately, pain is kind of whatever the patient says it is, right? So they say, hey, I'm a 10 out of 10. And they look like they're sitting there quietly, comfortable. They still say it's a 10 out of 10. To them, it's a 10 out of 10, right? And so looking at acute versus chronic, like how long does acute pain last? This could be variable, right? It could be a couple days, could be a week, it could be 5 minutes. It just depends. But again, chronic pain, we're going to be thinking about kind of long-term stuff. We're thinking typically longer than a week, maybe a month, years, lifelong, depending on the case. And again, it could either be persistent, they're always feeling that pain, or it could be more intermittent, right? It could be a mixture of the both as well. That's why we're going to be focusing on our medications. We're going to see that there's things that are better for more persistent pain, and there's going to be things for more of that sort of intermittent sort of pain on top of that. And again, our medication therapy needs to be guided towards that. And then again, looking at the etiology, we're going to treat basically somatic and visceral pain sort of together. And you guys know the difference between those different pain types, right? So for instance, when I say neuropathic pain, what's the main issue? The nerves, right? So again, you're going to find that the therapy for that typically differs a little bit with neuropathic pain than for the somatic and visceral. We're going to look at those different options there. The nice thing about the neuropathic pain, we've already covered most of the meds we're going to use there. So it's just going to be kind of a brief rehashing of that. Anyway, as I mentioned, acute pain lasts hours to weeks versus say months to years. More chronic pain. Typically, you're going to find that acute pain may be acutely disabling, but patients typically regain function afterwards. However, some of those patients will go on to develop chronic pain. That's an important consideration too. Again, everyone who has chronic pain, they probably started out with acute pain, right? And with chronic pain, typically it tends to be pretty disabling, right? They can't get around because their knees are so bad from their osteoarthritis, they can't get to work, right? They can't get around, do the things they want to do anymore, things like that. When you get into chronic pain, that's where we're going to be focusing on the kind of the heavy emphasis on multimodal therapy, right? Shooting for not only just opioids, but also non-opioid therapies, non-pharmacologic therapies, etc., right? So again, not to get too big into describing the different types of pain. Obviously, neuropathic though has a pretty characteristic sort of description, right? It's kind of burning, tingling, shooting pain. What type of patients are likely to have neuropathic pain issues? Diabetics. Well, diabetic patients, I should say. Obese patients, perhaps. Yeah. Well, like MS, right? We talk about certain autoimmune conditions that could be affecting the nerves. MS is a big one. Fibromyalgia. There's a lot of different neuropathic pain conditions. Some of the medications we actually give patients can cause neuropathies, right? We talked about certain cancer drugs that can do that, like the vinca alkaloids can actually cause peripheral neuropathies, right? That hand-foot sort of distribution. So again, there's lots of different reasons for that, but that's typically how it's described. It's that kind of hot, kind of tingling, shooting sort of pain. And again, the reason why we care about this, especially with the effects of chronic pain, is that it costs billions of dollars, not just in the fact of what we have to treat the patients with, but also the loss of productivity, right? And there's a lot of different analyses out there that you can see that basically when a person's taken out of the workforce, like there's a certain amount of money lost associated with that because they're not productive, essentially. Not only that, but quality of life takes a big hit, whether it be psychological, social, spiritual, etc. Actually, I saw a video. You ever guys watch those videos online where it's like see someone like on a skateboard or a bike and they're doing some kind of crazy trick, and then they ultimately end up wiping out and get hurt, and you say, oh, that's so funny, they wiped out and they really hurt themselves. It's a bit of that schadenfreude, right? Actually, I saw one video where this guy was trying to take he's on a BMX bike and tried to go up a ramp on a moving car, and ended up the car was not underneath him with the other ramp when he came back down, and so basically you saw him just collapse, right? You say, oh, haha, that's so funny. Actually, when you look at the comments, they were saying, oh no, actually that guy developed like really disabling sort of pain, was never able to ride his bike again, ultimately committed suicide, right? So again, this is one of the things where chronic pain can be a big deal, and we see a lot of these patients, especially from the tox side of things, where again they're given access to a lot of these medications. It can be very, very dangerous, and if you combine that with now they have depression related to their pain, you can see how that can be a very dangerous sort of combination there, right? Next time you won't laugh at those videos so hard, will you? Think about the person behind the pain, right? Anyway, so again, looking at pain management, to get optimal pain management, you need good pain assessment, right? So what are some ways we can assess pain? Just ask them, like, just talk to the person, right? So again, this is all part of your history you're going to be taking, like, where is it located at? Where does it radiate? You know, how long has it been going on for? What makes it worse? What makes it better? That's really important, especially when you're trying to look at your drug therapy. So ask about what's worked for them before and what hasn't worked in the past, right? So again, when they say something like, well, I took some Tylenol, but it didn't work. What do you want to ask about that Tylenol? The strength, how much did you take? You know, if they were only taking, say, 500 milligrams and didn't really do anything for their pain, well, maybe that is an insufficient dose. Maybe they need a gram, right? We have the same thing about, especially for like fever management for patients coming into the ER, like for a PTR visit, we'll ask them, how much Tylenol did you give? Only give 1 ml. Well, the kid probably needs like 2 or 3. So again, ask about the dose they're receiving. That can be very helpful information, right? They say, hey, I've tried NSAIDs before, they don't work for me. Well, why don't they work for you? Oh, I developed a GI ulcer. Okay, well, that's important information to us. Not the drug may not be effective, but maybe you need to change your therapy up a little bit. Maybe what could I do to get around that sort of issue with the patient? I could use a PPI along with an NSAID. I could use misoprostol. I could use a COX-2 selective NSAID, right? There are different options there that may have made NSAIDs a better option for that patient, okay? Those are things to think about. Again, the pain characteristics can help you decide between more of a visceral / somatic sort of pain versus more of that neuropathic pain. And again, I only make that delineation because the therapy differs pretty greatly between the two. And also asking about the intensity of the pain, right? And so typically, how would you ask about intensity of pain for a patient? A scale of 1 to 10, 1 being no pain or very little pain, 10 being what? I like to say like your arm being sawed off with like a dull spoon, right? So that's the worst pain you could possibly imagine, right? And again, asking a guy like, okay, well, 10 out of 10 is like giving birth. Like, a guy's not gonna know what that's like, right? But however, a mom, they'd be like, okay, yeah, my pain's definitely not a 10, and it's like only a 6, right? So again, it's all about perspective here. And actually, if you can watch this on your own time, as an older comedy bit where a guy was like going into the ER for pain, and he was basically trying to figure out what number he should tell the nurse to make sure that he actually gets something to actually treat his pain. Because if he comes in and he says a 4 out of 10, what are they gonna give him? Some Tylenol, maybe get some ibuprofen. If he tells them it's a 10 out of 10, what are they going to think? No way, you must be faking it. We're not going to give you anything, right? So he settled on 8. 8 was the perfect number. He said 8 and got a dose of morphine. So he's going through telling everyone else in the ER, hey, tell him 8. 8's got it. 8's the winner here. Get you some morphine, right? Anyway, so you can check that out. But again, people get like tied to these numbers. It's very odd. So, again, I deal with more of these people when they kind of take too much of their medications from the tox side of things, right? But my wife, she focused on pain management, which is why I think we have such a good chemistry there, because she treats them with too many opioids and then I reverse it, right? So we're kind of like yin and yang a little bit. But she was, she did her second year residency at the VA, and again, a lot of chronic pain issues with these vets, and so she would say, she'd come into a room, talk to a patient, their pain's, this chronic 6 out of 10. It's been that way for years, right? And so they go through and they look at his medications, and they go through and they fix all this stuff. They come in the next day and say, hey, how you feeling? He said, oh, I feel so much better. And what's your pain? 6 out of 10. Like, okay, well, you said you feel better. They get like psychologically sort of like tied to these numbers, right? Because again, it becomes something that it's kind of like a badge of honor they wear almost, where it's like, that's my pain. It becomes very personal to them. And so again, you have to look at other assessments, right? Well, the guy still says he's a 6 out of 10, but he's able to get up and walk around the unit. Okay, well, that's functionally, it's an improvement, right? So those are things you're gonna be looking for, not just the subjective measurements, but the objective measurements as well, right? The functionality of them. Anyway, there's some other ways you can do it as well. So for instance, we have things like visual analog scales, where basically you'd have like a 10 centimeter line here. What do you think the benefit of using something like this would be? That's okay. Because again, the basically say, hey, on one side of the scale you have no pain, on the other side of the scale you have the most pain. Where would you put your finger at as far as assessing the pain? What do you think could be a benefit there? Yeah, they're not tied to a number, right? So again, they can. You're unlikely to have a person be able to, exactly put their finger at 6.3 centimeters every single time, right? So again, by measuring that, you can actually measure some differences there, and they're less tied to that number specifically. So that could be one way to do it. And again, some people, it just depends on how you describe it, right? What is mild versus moderate pain to you versus mild versus moderate pain to someone else, right? So again, sometimes the descriptors can be a little bit misleading there. Why do we use the Wong-Baker FACES scale there? Who's that good for? Good for kids, right? Because again, if you ask, hey, little kid, like, what's your pain right now? Scale of 1 to 10. My daughter would probably say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, because that's basically that's all she knows, right? So she doesn't know numbers. But if you say, how would you describe your pain if you had to, what does your pain look like right now, right? And they can point to whether it's crying or has kind of a meh sort of face, whatever the case may be. That can be somewhat useful, right? And then you can equate that back to an actual number scale. Other things like, for geriatric patients, has anyone actually ever seen a mercury thermometer in their life? Very few probably have, but that's what that looks like, and that's what older patients are probably used to seeing. And so they can again say like, well, how severe is your pain? How hot is that pain essentially? And being able to equate it to that sort of scale, right? So again, all goes to the perspective of the patient. So again, asking about the modifying factors, what are making it better, what's making it worse. I was when growing up, and again, if you know anything about my humor, a lot of that comes from my father, as you might imagine. And so whenever like I'd say, my toe hurts, he would just kind of step on my other toe and be like, okay, well, how's the pain now? And he's like, oh, that other toe hurts now. He's like, there you go. Now you're not worried about the original toe. No more pain, right? Doesn't really work. But think about modifying factors, right? What are some other things in regards to like activity and other things that are going to be affecting that? And again, very, very important, figure out the previous treatment. What has worked for them, what does not, because if you give them something that they already know is not going to work for them in their mind, it's not going to work, and they're not going to be very as likely to go back to you in the future. And then also look at things like behavioral issues, right? So look at things like substance abuse history. Look at things like, do they have concomitant bipolar disorder or depression? That could be also playing a role here, right? Again, if you have untreated depression, long chronic pain, you're going to find that you can get really good pain management on board, but they still feel depressed. They may not really be able to get that function back like they would otherwise. So you got to treat from all aspects of the patient. Anyway, and again, medication history is super important. Nowadays, you have extra tools that are available to help you out with medication history, right? So you can ask a patient, and again, what could be a risk with asking a patient to tell you all their medications are on and the doses and whatnot? What's some risk there? They may not know, right? They may not have a good idea what their actual med history is, or what else? They may not tell you accurate dosing, right? So they may say, like, oh yeah, I'm taking methadone 60 milligrams Q6. That's a pretty big dose, but it's not unheard of. There's actually an error that happened at one of the local hospitals where a patient came in. They had a program basically where if you come into the ER, you have to do a medication reconciliation. They would have a pharmacy tech. Again, if you guys don't know, pharmacy techs have no real medical background, right? They can work in a pharmacy, but they don't really have any sort of background as far as like physiology and things like that. But they go and they will ask the patient, hey, what medications are you on? They'll take a list. They'll take that list over to the pharmacist. The pharmacist will verify it, and then that's in the record, right? So that way, when you come along as the admitting person, you can just say, okay, I want this med, TC that med, and then they're admitted, right? One guy came in and he was admitted, and he said, oh, my methadone dose is like something pretty high, but it wasn't anything unreasonable for someone on methadone long term. And no one actually called to double check on it. No one checked with the methadone clinic. No one checked with anyone to double check that. So patient got admitted. The pharmacist verified it. The provider reordered it. And then what did they find the next morning? They walked in the patient's room. He was very soundly asleep, not responding to physical stimuli, and had to get some Narcan to reverse that. So again, these are things you want to double check on. Nowadays, there's additional help with that. Anyone ever heard of eForce before, or the prescription drug monitoring program? That's going to be something that's mandatory now with some of the new laws in place. You have to check that anytime you're writing for a controlled substance for a patient. You could be writing for a benzo for their anxiety. You could be writing for opioids for their pain. Doesn't matter. You have to check on this stuff now. And again, that program is nice because it'll actually tell you where they've been filling at, what they've been filling, who the providers were, and all these sorts of things. So that way, if you see someone who's been filling it, 10 different pharmacies in the past week for oxycodone, something's up, right? Versus if they are filling it very diligently, they're only seeing one provider, all sorts of things. And so that can give you an idea of, okay, well, what have they been filling? What do they have access to, et cetera. And again, say you couldn't get a history. Say a patient's not really communicative, you don't have any family around. What else could you do to get the medication history? Well, where do most people get their meds from? If you had to guess and put money on it, you'd probably say Walgreens, CVS, Walmart, Publix, right? You can call the pharmacies, right? You can call them up and say, hey, here's a patient information. Can you help me out? I'm trying to get a good medication history. And the pharmacist there will help you out. So that's always one thing you can do in the back of your head. You may not have time for it, but it could be something useful, especially if you have like a PA student working with you. Say, hey, go call the pharmacies, figure out what the heck they're on. We did that all the time when I was in fellowship. You have like pharmacy students and stuff, and just say, hey, go do the grunt work, right? I'm here doing the big picture thinking, right? Anyway, labs are really important. What kind of labs do you think we want to look at for these patients?
UA.
What could a UA tell me? Okay, so I can do a urine drug screen. Oh boy, you're going to get me on the soapbox, aren't you? So I can do a urine drug screen, right? So what can that tell me? can tell me, or do they have the presence of certain illicit substances in their system? What are some things they test for? Amphetamines. What else? Benzodiazepines are on there. Cocaine's a big one. Cannabis, so THC is detected on there. So if you have someone who's taking cannabidiol, CBD, is that going to show up? I don't know. Is there any THC in that product they were taking? They may say there's no THC. It might be a little bit. So who knows if they'd actually pop positive. They check for barbiturates. They check for opiates. They check for cocaine. I think that's all. Those are the main ones, right? But again, you have to know what your urine drug screen is actually covering for. The other problem is that urine drug screen is only testing for certain things. So if you're taking heroin, if you're taking morphine, it shows up very nicely because it looks just like the original, stuff we get from the poppy plant, essentially. But when you get into more synthetic stuff like fentanyl, methadone, a lot of urine drug screens don't check for that. So just because they come up negative does not mean that they are not actually exposed to those substances, right? So again, you get a lot of false negatives. You also get a lot of false positives. If someone does a bunch of Sudafed because they have sinusitis and they take a urine drug screen, what do they show positive for? Amphetamines, right? So then all of a sudden you're like, you've been abusing amphetamines. And you're like, no, I haven't. I just got stuffy nose, right? So again, you have to take it in context. You have to know what your test is actually testing for. What are the common false positives and false negatives? You'll get a feel for that when you work with these screens if you do them with any routine basis. And you can call the lab if you're ever not sure. They can give you all the information on what usually shows positive or negative on those tests. Anyway. But the reason why I say it's soapbox is because I have a lot of providers that will order urine drug screen as something that's either negative or positive, and they'll say, absolutely, this is it. I'm like, well, not necessarily, right? So again, there's a lot of caveats with urine drug screens, okay? Anyway, but also look at things like organ function, such as their renal function. Look at their hepatic function, because again, if they're not working very well, they may hold on to these drugs. They accumulate a lot of products here, and that can lead to a lot of toxicity, okay? So you have to look for that. Look at history of substance abuse. Doesn't have to be opioids. It could be to any substance, whether it be alcohol. It could be, these addictive personalities tend to be addictive to multiple things, right? So it could be a gambling history in their family history. It could be any of these things that may just kind of perk you up and make you think, hey, they are maybe are at risk, right? And then, of course, look at their psychosocial assessments. Look at whether they have concomitant depression. Maybe they've never been diagnosed with it before, and this is the first time that anyone's actually asking them the questions. Always screen for that stuff as well. So anyway, so when you're dealing with pain, again, this is more on the chronic sort of basis here, but what do you kind of notice about the pain in red here? There's always sort of a basal amount of pain that's going on. When I say basal, what does that mean? Besides that, what you put on pizzas and stuff. There's always kind of a baseline amount of it that's there, right? So some of these patients with chronic pain are never out of pain, right? They're always going to have some degree of pain there. And then they have these little spikes here that happen, right? We call that breakthrough pain. We call that intermittent pain on top of what their basal sort of pain level is. And so again, normally they might be sitting at a 4 out of 10 throughout the day, but then they have little spikes, maybe a 6, maybe an 8. Oh man, I had to get up and actually go to the grocery store. Now my pain is really starting to flare up. I was a 10 out of 10 for a couple minutes there. An hour there. So it's important to focus on your pain management to try to cover for both of these, right? So that's where we're going to see a combination of using long-acting medications are going to be good for covering the basal amount of pain the patient's experiencing. And then we're going to have things for breakthrough pain. It's going to be used on an as-needed basis, right? So you'd say, for instance, you could use long-acting oxycodone throughout the entire day. Say you take that twice a day to give you 24-hour coverage. And then you have something on top of that, say something like oxycodone and acetaminophen, that are good for those breakthrough pain. Okay, so just remember that's kind of the modalities we're shooting for, and we'll cover the meds in more detail in just a minute here. But just know that's kind of what we're going to be aiming for. This will be important as well when we talk about other things like patient-controlled analgesia and things like that. It's covering for both the basal amount of pain and then the breakthrough pain. Okay, and again, looking at the actual treatment approach, some of it can be based off of this WHO ladder approach, the World Health Organization's ladder approach. Some of it is based off the etiology of the pain itself. So again, if they come in and it's burning, stinging, shooting pains like it's neuropathic, you're going to treat that differently than it would be if it's, say, coming in as a, obviously, open femur fracture or something, okay? But anyway, so looking at the ladder approach, basically it says start low and go slow. Same rule applies like we've talked about it in numerous other places here. Start low and go slow, right? So again, if you think about pain management, you can think about it kind of like being like a magician, right? So is it acetaminophen? Is that a very good magic trick? It's like grandpa pulling a quarter out from behind your ear, right? Toradol, what kind of drug is Toradol? It's an NSAID. It's usually parenteral NSAID, usually IM, IV. That's like pulling a rabbit out of a hat. If I go with some fentanyl, what's that like? that's sawing the assistant in half, right? That's the big trick, right? So again, you don't always want to start the show with a showstopper. So again, consider how they're approaching. You can always give them more medications. You can't take it back once they've been given it, okay? Now, does that mean every single patient coming in, whether they come in for traumatic injury, whether they come in for the sniffles, they all start at acetaminophen? No, you can bump it up beyond that, right? So again, if they come in and they have an obviously displaced femur fracture, and you give them acetaminophen, you're going to get in trouble, right? Because they're going to be like, you did not actively manage that patient's pain. You can start with the big guns at that point, right? So again, look at the pain, assess what the etiology is, and you can start at the appropriate steps, right? You don't have to start at step one. But in general, when you're going kind of on the stepwise approach here, you start at the bottom, typically non-opioid medications, right? So again, your acetaminophen, your NSAIDs, things like that, right? When I say adjuvants, what does that mean? Kind of extra stuff to kind of help out, right? So for instance, if I had someone with neuropathic pain issues, we can look at things like tricyclic antidepressants. We can look at things like selective norepinephrine reuptake inhibitors. We can look at things like capsaicin, things like that, which are going to be able to help out, okay? But again, mainly focusing on non-opioid therapies, okay? Then when you bump it up, we start to look at more mild to moderate pain. This is where you can potentially get into the opioids. Typically, when you're kind of on the step two sort of, at the ladder here, typically you're thinking more oral options, right? So again, you'll find, and we'll kind of talk about it on the test. I'm not going to ask you specifically which ones are IV, which ones are PO, but I'll kind of talk about them in more broad aspects. And as you get more exposure to them, you'll get a feel for which ones are kind of oral versus IV. But usually oral options here, right, are going to be good. And then when you kind of go up to the step three, this is where you're definitely going to be using more invasive opioids. So typically it's going to be IV opioids, things like morphine, things like fentanyl, things like hydromorphone are going to get involved here. And you're still using your adjuvants. You're still using non-opioid stuff. So again, by using multiple different modalities here, you're going to get better synergism. And the ideal is, what's the ideal opioid dose for your patient? 0 would be ideal, right? So again, the idea is that by using other medications, by using other modalities, you're going to find that it is going to be opioid sparing. That's always the idea here, is you want to be opioid sparing as possible, to use the smallest dose we can, because we're going to mitigate a lot of the big issues we're going to see with opioids in the long run. Okay, that's always the goal. And again, if you look at the assignment I gave you, what did you notice about the different pain options I asked you to write a prescription for, or an order for? You have more an order for mild to moderate pain, and then you had an order for severe pain. So start to think about, like, okay, well, what would be a better option for severe pain versus just mild to moderate pain, right? So when you go over these medications here, does the patient always need an opioid just for mild pain? Not really, right? You know, do they always need an IV option for severe pain? Maybe. It depends on what's going on, right? So just a thing to think about. And actually, I don't know if I mentioned this story, but I saw an order from a PA the other day that came through, and it was basically, it said morphine, Q2 hours, PRN pain on a scale 1 through 10. Does that sound like an appropriate order? So if they have a pain 10 out of 10, they're getting morphine. If they stub their toe and they have a pain 1 out of 10, they're still getting morphine. So again, looking at things like, what are your indications here, right? So when are we telling the nurses to give a med versus not give a med is very, very important. So you need a really clear instruction of that sort of thing. And so we'll talk about that as well in detail in just a few minutes. Anyway, so again, you don't start at the bottom rung of the ladder. You can always go up based on the etiology, based on the severity of pain the patient's experiencing. So first off, let's look at, say, some non-opioid sort of therapies here, right? So again, focusing on inflammation. What are some options we have here to deal with acute inflammation due to an injury? NSAIDs, right? So we talked about non-steroidal anti-inflammatory drugs. We're talking about inflammation, right? So again, NSAIDs are going to be a big component of this. They have a big inflammatory sort of response, causing a lot of pain. What else could I give? It's also a very potent anti-inflammatory. Steroids, absolutely. So corticosteroids could absolutely be used here. So again, looking at the etiology, if I have someone with rheumatoid arthritis is having a very severe flare-up, or MS with a severe flare-up, what do you normally treat those patients with? Give them corticosteroids, right? Because they're potent anti-inflammatories. They deal with that pain. Does that mean I want to give everyone with pain, with inflammation, corticosteroids around the clock? No, because there are a lot of side effects with it. But when used sparingly, it can be very potent there, right? Dealing with the inflammation. NSAIDs, on the other hand, can be used with more regular basis. Some patients will be on these every single day for the rest of their life, depending on what's going on. But anyway, they're dealing with the issues of these inflammatory mediators being produced, like prostaglandins, histamine, things like that, to try to decrease that inflammation. Now, I'm not going to get all the specific details here, but one of the things you see is that when you're releasing these inflammatory cytokines, they're also really sensitizing these nociceptive fibers, right? And when I say nociceptive, what does that mean? Pain sensing, right? So again, these are pain fibers, essentially. They're going to be communicating through the spinal cord up into the CNS, okay? So they're experiencing pain at the nerve terminal, right there where the pain's actually occurring there, they're getting sensitized, so they're more likely, they're getting more likely to depolarize and send those action potentials up through to the CNS to cause pain. And so we're going to see there's several different steps along the way we can actually interfere with that to try to decrease what pain that patient's actually experiencing, right? So again, we can find some drugs are going to work in the spinal cord, some drugs are going to work on the nerve itself. Anti-inflammatories work on actually decreasing that inflammation and trying to decrease that sensitization that occurs there in those nociceptive fibers. So again, looking at, say, a site of injury here, so imagine you say a cut in the skin, you're going to see all these different things like histamine, serotonin, bradykinin, and things like that are going to be sensitizing these fibers here that are more likely to send these signals up through the spinal cord up into the brain, and that's where we actually detect the pain itself, right? So we're going to find that we could do things like decreasing the inflammation here. That's going to be one way to deal with pain. So when we look at NSAIDs, what are their main actions? So they're anti-inflammatory, but they're also cause analgesia, and that's the main way they're going to be doing that, is causing analgesia at the actual site itself by decreasing that inflammation, right? Also good antipyretic, so we know there's some central actions as well they're probably doing additionally, but they're going to be doing that. What could I do to maybe decrease the actual transmission through these fibers here? Is there anything I can do to like interrupt that? Well, that's not the question, so chances are there probably is a way to do that, and there is. This is where we can actually have things like local anesthetics actually come into play here, right? So again, we've talked about a local anesthetic before. Anyone know which that is? We talked about it with the heart and arrhythmias. Lidocaine, yeah, absolutely. So lidocaine, antiarrhythmic, also more commonly used as a local anesthetic. What did it do for the heart? Why did it act as an antiarrhythmic? Blocked. It's a 1B antiarrhythmic, if you remember. Block sodium channels, right? By blocking sodium channels, you decrease that ability for the myocytes to fire off an action potential, and you disrupt that arrhythmia, right? Well, same thing happens to the nerves as well. So I can actually inject it into a local site. Say, for instance, someone comes in, they have a laceration, I need to suture it up, or not me, but someone else needs to suture it up, and they want to try to numb up the area. They can use things like local anesthetics, and that will block those sodium channels, and then you can't propagate those nerve impulses up through the spinal cord up into the CNS. So the pain's still there technically, but the patient's never going to feel it. That's a big way we're starting to focus now, especially after like a lot of like orthopedic procedures, more minor pains, neuropathic pains even, to try to manage that pain by using things like local anesthetics. We'll talk about those a little bit later on. But things like local nerve blocks, things like using epidurals and things like that to try to decrease pain at certain areas by decreasing the actual transmission itself, right? Because they don't ever receive like a local anesthetic and how it kind of feels afterwards, like it's numbed up, right? You can't feel any sensation. So again, very good at decreasing that pain. And again, no opioids have to be used potentially due to that. So again, by using NSAIDs, we're going to be working on the which pathway? The arachidonic acid pathway to decrease the activity of which enzyme? COX enzyme, right? COX-1, COX-2 typically with a lot of the non-selective ones. Very good at decreasing that inflammation there. Again, you're going to typically find that NSAIDs are better for more mild to more moderate pain, right? They have very severe pain if they just have a dislocated shoulder or femur fracture, like, it's not going to be a good option for them. It could be useful in addition to some opioids, some other stronger pain meds, but better for more mild to moderate pain. So as I mentioned, the big differences between the meds we're going to be looking at is going to be one, the irreversibility of them. So which one's an irreversible NSAID? Aspirin, right? Aspirin is not used too frequently because, again, we know there's bleeding risk. We know because of its irreversible nature that it tends to make the side effect profile not great. So some people use aspirin for pain, but not as commonly anymore nowadays. Usually we're going to be focusing on reversible inhibitors. That way when they're out of the system, bleeding risk is gone, no further effects from the drug. And then typically we're going to be looking at meds that, for the most part, are going to be non-selective for COX-1 and COX-2, but we know there are some options for more COX-2 selective agents, right? We know the COX-2 selective drug we mainly use. Celebrex, so celecoxib is going to be the big one. Meloxicam is another good one that has some selectivity, not as much as Celebrex, but is pretty good. And again, the big risk with using a non-selective NSAID is what? Ulcers, right? Again, you're decreasing that GI protective barrier, basically letting the acid and all those protein or all those enzymes eat through the stomach, right? So ulcers is a big thing to really focus on. And so getting into the etiology-based treatment here, you can see that for more somatic and visceral pain, this is where we're going to be focusing on our anti-inflammatories, right? Now notice acetaminophen is not an anti-inflammatory, but we'll talk about its use in a little bit. And then you're going to use plus or minus steroids. For the neuropathic pain, this is where we're going to get into things like antidepressants, anticonvulsants, muscle relaxants, drugs like baclofen, and then plus or minus opioids. Now again, the ideal is use as minimal amount or no opioids if possible. Again, is that going to be ideal for every single patient? Is it going to be reasonable or possible in every single patient? No. Some patients are going to have to be on opioids regardless, but try to get down and use as few drugs as possible, using as ones with as few side effects as we can. That's where we're going to get into some of the adjuvant therapies. So, and again, looking at dealing, and again, this is all kind of stuff we talked about, kind of incorporating both pharmacological and non-pharmacological modalities, looking at the psychological aspects of things. Do they have untreated depression? Looking at behavioral issues. Do they have a substance abuse history, etc.? Very, very important looking at that. And again, our goals need to be very clear with the patient on what those goals are going to be and come to an agreement. Because again, patient comes in, ideally, what should their pain scale be to them? They would like it to be a 0, but if you let them know, hey, you may never get to a 0 again, buddy. You know, based on your injury, based on whatever the case may be, you may never be a 0. But we can get you from an 8 to a 4. That's pretty good, right? And so again, looking at the functional aspects as well. Can you actually go back to work? Can you, actually go out and go to see a movie? Can you go grocery shopping? Things like that. These are also functional things you want to emphasize, so that way they know that, okay, well, maybe the pain's not a 0, but I can actually live my life again. That can be very important aspects of it as well, right? So you got to have that kind of honest conversation with them. So, and again, treatment needs to be individualized to every single patient. Everyone's going to be a little bit differently, responding differently based on the type of pain, severity, etc. And you're going to find that patients are going to have some pharmacogenetic variability insofar as how they respond to opioids, right? Opioid receptors are not going to be unique to every single person, but some people are going to respond better to certain types of drugs versus others. A lot of times how they respond is more to do with the adverse reactions they experience. We'll talk about some of those as well. And again, if one agent's not working, you can always try something in a different class or something that's structurally a little bit different. We'll talk about those in a few minutes. So again, getting into our specific pharmacologic therapies here, acetaminophen we'll talk about briefly, non-steroidal anti-inflammatory drugs, opioids, we're going to spend a lot of time there, and then we'll talk about some of the adjuvants as well. All right, so acetaminophen, or Tylenol. Anyone know where Tylenol name comes from? Have I wowed you with that trivia bit before? So if you look in the name, acetyl para-aminophenol, that's where APAP comes from, the APAP. So if you ever see that abbreviation, that's referring to acetaminophen. Again, what's the problem with abbreviations? More likely to get mixed up with other things, so again, be careful using your abbreviations. But if you're looking actually where the name Tylenol came from, again, you can wow all your friends with this. Look, there's a TYL and then an ENOL. So again, I don't know how long someone had to actually stare at that name before they came up with the brand name Tylenol, but that's where it comes from, okay? Anyway, so what is Tylenol good for? It's good for pain, so it's an analgesic. What else? Fever, right? Is it good for inflammation? No, no effect on inflammation, right? We don't even know really fully how it works. Some people thought there's like a COX-3 up in the CNS that maybe it works on. We're not really sure why it works, but we do know it has a very good safety profile. Has a pretty good job when it's used with other agents to help decrease pain. It's definitely opioid sparing, and it's really good for more mild to moderate pains. Okay, so again, typically like when we're writing post-op orders for patients coming out of surgery, we'll have sort of a 3 medication sort of combination, and for the mildest of pain, typically if it's a scale of say 1 to 3, we'll give them acetaminophen most often. So again, very mild pain reliever. It's good for like low back pain, osteoarthritis, very widely used. And again, this is a really big deal to ask about patients about previous use, because again, where can you get acetaminophen from? Everywhere. You can probably go to any store in the Mall Millennium, probably find some Tylenol somewhere, right? So you can go to Costco, pay $10 and get a 55-gallon drum of this stuff, right? It's available, it's everywhere. And so because of that, you need to ask about its use, because some of the drugs you're going to use, what do they often contain with them? Acetaminophen, right? A lot of them come in combination with acetaminophen. What happens when I get above a certain level of acetaminophen? What's the main organ that takes a hit? The liver, right? So you always think about liver toxicity with acetaminophen. Very, very safe in therapeutic doses. However, patients with liver dysfunction, people taking too much, they're going to be more at risk for developing hepatotoxicity and can absolutely be fatal, right? So again, you need to be really careful with this. And again, it's very sort of insidious in its onset. It's very sort of slow acting, and so people may not realize how big of a trouble they are in until it's too late in some cases, right? And actually, this is one of the most common medications you'll find patients will overdose on. I remember I had one guy who was in the ER. He's basically yellow from head to toe. I've never seen someone so mustard yellow in my entire life. LFTs were through the roof, and INR was like 5, and the guy had overdosed on Tylenol, but he basically said, "Oh, I want to end it all." Took a ton of Tylenol and went to sleep. And he said, "Okay, I'm not going to wake up." Tylenol takes like 24, 36 hours to kick in. So he woke up the next morning. He's like, "Wow, I lived. I must be meant to be here." And then he decides to go to the library and look up acetaminophen toxicity, and he's like, "Oh no, this is going to get bad real soon. And then comes in, he's like, completely jaundiced, and we were able to get him back. I were able to give him a ton of the antidote, but just know that it's you want to monitor for this sort of thing, right? The hepatotoxicity is very real with this drug. Other things to think about as well. We actually have an IV form that's available that can be opioid sparing as well. We call this Ofirma, and we actually find that when used even as a single dose in the post-operative period, you actually find that this helps to reduce the amount of opioids patients need overall, which is great. And again, we're going to find that, especially in the post-operative period, the fewer opioids you have to give means the sooner the patient's going to be eating, patient's going to be getting up, moving around. The sooner you can get them discharged, right? So you get to get them home and get someone else in the hospital, right? So again, it's very important to get them out as soon as you can. Again, patients don't like to be in the hospital anyway. They want to get out of there. The less opioids you have to use, usually the faster that's going to be. And again, other routes you can use, certainly if they can't tolerate PO routes, we can use things like rectal routes as well. Who would you not want to use the rectal route in? Remember, neutropenic patients, right? If you had someone who's getting treatment for cancer and they're febrile, you don't want to give them rectal Tylenol, right? Because you worry about what? That friable tissue, right? Friable means what? I can get it from McDonald's. No, it means it's brittle. It's not very structurally sound. It's able to be damaged and punctured through, and then all that nice bacteria you've been growing in your rectum is going right through, and that can cause sepsis, right? So again, think about these sorts of things. Who you don't want to give certain routes of medications to. That can be very, very important, right? And again, the nice thing here is you really see like almost no GI side effects, no hematologic effects, very, very well tolerated by almost all patients, right? So the biggest thing that you just have to worry about that dose-dependent hepatic necrosis that can occur here, right? And so again, the kind of classical recommendations don't go above 4 grams a day of Tylenol, but that's again Tylenol from all sources, right? So imagine if you have someone who's receiving hydrocodone and acetaminophen 5/325 on top of getting Tylenol 650 every 6 hours. It's very easy to go above that 4 gram limit. You actually want to shoot for something even lower for patients who have a history of hepatic impairment, right? Maybe only, say, 3 grams for some of those patients, right? So be very careful with that. We definitely want to monitor if they're going to be using it for a continued period of time there. All right, then we have our analgesics. So again, these are going to be differentiating themselves from Tylenol, mainly because they have more anti-inflammatory sort of properties here, and we know that's because they're inhibiting things like COX-1 and COX-2. Again, which one of those are constitutive? Constitutive means it's there all the time. COX-1, COX-2 is the inducible form, right? So that's what's going to be more ramped up when you have more inflammation. That's why COX-2 inhibitors can be more useful for that sort of inflammatory mediated pain. Again, we've seen diagrams like this before. Just know, again, they're inhibiting that cyclooxygenase pathway, so having less prostaglandins being made. Less prostaglandins means less inflammation, which means less sensitization of those nociceptive fibers. Less pain being transmitted up to the brain. So again, we have aspirin, we have ibuprofen. We've covered a lot of these already for the most part. We'll talk about again when we get to the actually, we do already cover rheum. Is that on the test? No, all right, we'll get there eventually. We'll talk about NSAIDs a lot there as well. Again, we have things like indomethacin, Ketorolac, or Toradol. Some people just say Ketorolac. I don't really care about the pronunciation there. Again, all of them work very, very well for decreasing inflammation, decreasing pain. Again, are they going to be as good as an opioid as far as analgesia goes? No, but they're good as an adjuvant. They're good as kind of a helper medication there. A lot of patients, especially for less painful sort of procedures, they have a lot of patients who are coming in through the ENT service who go in and they have either like a TNA or they have a tube place or something like that. If they have to get admitted to the hospital, oftentimes our providers will just give them acetaminophen and ibuprofen and just schedule those so that way they get one or the other every 3 hours. And that way they have to get 0 opioids, right? So in some cases, for less painful procedures, that can be very beneficial to some to avoid opioids altogether. A lot of them have different routes here. Usually, if you think of like an IV NSAID, Toradol is going to be the one that we go with most frequently. Again, I'm not going to test on that specific point, but again, when you see that in ERs in the hospital, it's a more common NSAID you're going to find being used parenterally, either IM or IV. It's going to be Toradol, Ketorolac. And again, when you're giving them for more chronic treatment, you give them 2 to 3 weeks, see how they're going to respond to it, see what kind of side effects are going to manifest before you say, well, this one's not really working, maybe we'll switch them over to something else. And just because you fail ibuprofen doesn't mean you're done with all NSAIDs. It means you just switch over to a different one and see how that works for you, right? So maybe meloxicam works better. Maybe Toradol works better for you. It just depends on the patient there, how they respond. So again, what are the common side effects we see with the NSAIDs? GI is a big one, right? So again, see GI upset, certainly that can lead to things like GI ulcers and whatnot. Bleeding risk, but the bleeding risk is going to be most pronounced with which medication? Aspirin, right? Because that's an irreversible inhibitor of cyclooxygenase on the platelets there. Most of the other ones, as soon as they're out of the system, not going to have any big bleeding risk there. But it's important to consider, like, if a patient's going to go for a very big surgery that may be more prone to bleeding, you have to consider that, right? If it's just a laparoscopic procedure where they're basically just getting 3 holes punctured into them, not really big risk for a lot of bleeding there, maybe an NSAID's appropriate. Versus if it's something that's like completely open abdominal procedure, maybe you don't want to use NSAIDs in those patients, right? So again, a lot of it depends on the type of procedure having done, kind of weighing the benefits versus the risk of bleeding in those patients there. Obviously, some risk for hypersensitivity reactions, and we actually do not use these for the 3rd trimester of pregnancy, mainly because they can have some issues where either they can delay spontaneous labor, they can do things like closing up the ductus arteriosus too early in the fetus, things like that. So again, we don't use these in late pregnancy typically, but we'll talk more about that in the OB-GYN section. And again, be careful in patients who, if you ever hear someone have like aspirin-induced bronchospasm or they have an allergy or they had an asthma attack related to an NSAID, be careful with that. Anyone know the mechanism for that? We talked about it before. It's the leukotrienes, right? Because remember, if we block the cyclooxygenase pathway, everything gets shunted over to that lipoxygenase pathway, and you get way more leukotrienes, right? So if you see some patients who have the allergy, sometimes we'll actually give them something like a Singulair, like montelukast, and that can actually block that leukotriene action. They may safely be able to receive it. So again, kind of weigh the benefits versus risks there. And again, watch out for patients with renal impairment. Now again, why do I care about that? Because prostaglandins do what in the kidneys? They open up the afferent arterial, right? Prostaglandins are going to be vasodilatory there. If I give them an NSAID, they're going to get rid of those prostaglandins. You're going to find that afferent arterial is going to constrict. What does that do to your GFR? It's going to go down, right? And that can affect a lot of things, right? It can affect certainly your ability to clear things like creatinine and other waste products, but also it can affect other medications, right? Things like lithium was a big one we talked about. A lot of renally eliminated meds can be affected by that. So again, be very careful with patients who have pre-existing renal dysfunction. This is going to worsen that, okay? Just like an ACE inhibitor can, but on the other side of the glomerulus. But again, it's an important mechanism to think about. Started. So any questions from the first half? A lot of it was a lot of theory and things like that. I'll tell you a funny story. So my wife was working this weekend, and you guys remember the drug we talked about, dofetilide, Tikecin. Where did we talk about that? Remember, it was an antiarrhythmic we talked about. And remember what class it was? It's class 3. Class 3 antiarrhythmic, which means it does what? Blocks. Not sodium channels, that's class 1. Blocks potassium channels, good. And it can do what to the EKG?
Doesn't do good things.
Doesn't do good things? It does some good things, right? So remember, blocking potassium channels leads to slowed repolarization. And what is the repolarization phase on the EKG? What interval? QT, right? Remember, blocking potassium causes QT prolongation, right? Which can lead to torsades, right? So again, it can lead to ventricular arrhythmias, even though it is used occasionally to treat ventricular arrhythmias, right? So anyway, so one of the big things you have to do is you have to educate on it because it's a very sort of particular drug. You have to make sure you keep all your electrolytes in range, your magnesium, your potassium, a lot of dietary interactions you have to think about. So one of the things they do at her hospital is that the pharmacist will go and educate patients who are new start Tikecin patients. And so anyway, so she goes and talks to this older gentleman about it, and his wife is there, and she's like, okay, well, there's some side effects associated with the drug, and his wife was like, what kind of side effects? And she didn't know it at that time, but she's actually a dialysis nurse, right? So if you know anything about dialysis nurses, they're usually like kind of tough as nails, and they've seen kind of everything, because they see some pretty sick patients anyway. And she was like, well, you can see some arrhythmias, and the lady's like, what kind of arrhythmias? And she's like, ventricular ones. She was like, oh, we're going to get the paddles out, we're going to have to get the cardiovert my husband. And the husband had no idea. He was just like, oh my gosh, like, what is this drug they're putting me on? And the wife is just having kind of fun with him. But again, always consider who you're talking to, who your audience is, what their level of knowledge is, because again, you can change completely how you're educating. Obviously she had to talk to the patient because he's the one taking it, but the nurse obviously was much more medically versed. But anyway, and also fun when you can mess with the patients a little bit, right? If you can get their family to do it, you get in less trouble for it. Anyway, So getting into salicylates, right? So again, we know a lot about these already. We talked about them pretty much ad nauseum previously, talking about the irreversible effect on the platelets, etc. Good for cardioprotection. Not great as an analgesic. You don't see it used quite as often that way, but it's good to ask about it because patients may be taking these. Remember I talked about the BC powders and the goodies powders people take for headaches. Remember, a lot of times people don't even think about those as being aspirin. They just think about them as a BC powder. Anyone know what I'm talking about? I mentioned it before. There's little sachets of kind of wax paper that has the powdered drug in it. You just kind of dump it in some water or drink, and you can just drink it directly. So again, think about those things. Ask them, do they take a BC powder? Do you take a goodies? Because that's kind of a southern sort of thing for whatever reason that a lot of patients use that. But remember, the higher the dose you're going to be running up here, especially chronic pain, they're going to be treating themselves kind of throughout the day potentially. The more likely are to see a lot of these side effects here. Remember, tinnitus is one of the big things you're going to run into with aspirin. That tends to be pretty particular with that drug. You don't see that with a lot of other things. But if you had a patient, they're taking aspirin, ask them, hey, what kind of effects do you have? Do you notice anything with your hearing? They're, oh yeah, whenever I take too much of it, or I take an extra dose, I get this kind of muffled hearing, or I get this ringing in my ears. That's a bad sign, right? That's kind of a sign they're getting way too much of it. Some people get that at therapeutic doses. Some people are just a little bit more sensitive. But things to note, right? And obviously, get much more than that. That's where you get into this can be a very dangerous drug, very very potentially fatal when you get to very high doses. But anyway. Again, be careful with patients with bleeding disorders. If they're on other medications that can cause bleeding, like warfarin or Pixaban or other anticoagulants, be careful with those. And then, obviously, who do you want to be sure never to use aspirin in? Kids less than 16, they're post-viral, right? So if they have chicken pox, they get the flu, whatever the case, you don't want to use it in them because they are at risk for Ray's syndrome. Perfect. And again, we've covered that before. Again, it's kind of fatty encephalopathy. Again, a lot of these kids are post-viral. They kind of manifest similar symptoms to the early stages of Ray's syndrome, which is why it's very difficult to sort of identify until oftentimes it's kind of too late if they don't get good supportive care early. So, again, showing up, vomiting, stupor, lethargy, this could be those things that just seem, well, they're kind of sick, but then they kind of manifest as powder toxicity, as encephalopathy is no good. Anyway, so then moving into the other NSAIDs, we have our propionic acid derivatives. Again, it just goes to the chemical structure is how we're classifying these. Again, for the most part, they're all going to be very well absorbed. So most of these have oral options that are available. They get absorbed very well. Mostly you're going to be metabolized in the liver, so you do want to watch out for hepatic dysfunction, and then will be renally excreted. Notice here they're going to have typically less of your GI effects you get to this class of drugs, but they tend to be a little bit worse for things like renal toxicity, a little bit worse for hepatic toxicity. Okay, but again, used for a lot of different pain conditions: arthritis, dysmenorrhea, muscle pain, etc. Very, very good for more mild to moderate pain. So the ones that fit into this category include things like our ibuprofen, include things like our naproxen. Again, these are available over the counter. So again, ask about over-the-counter use or drugs they can get without a prescription. Because again, if you ask a patient, hey, what do you take OTC? Are they always going to know what OTC means? You take it for granted, they probably do. Most people probably do, but again, you want to specify things you can get without a prescription. It's a good question to ask. And again, things like ketotifen, phenoprofen, oxyprosin, a lot of things that will differentiate them are going to be things like their duration of action. So for instance, looking at the half-life of oxyprosin, it's 40 to 60 hours. So what benefit do you think that kind of holds for these patients? Yeah, decreased dosing frequency, right? So again, if they're going to be dealing with chronic pain that is a 24/7 sort of deal for them, then using something they can just take one time a day is going to be beneficial versus if it's just an acute sort of intermittent pain. Oh, I had a headache the other day, I took some ibuprofen. That's totally fine for acute pain issues. For chronic pain, you want to shoot for things that are going to be longer acting, right? They're going to be able to cover them throughout the day, decreases that pill burden for the patient overall, right? Other NSAIDs, we have things like indomethacin. This one I don't see used quite so frequently anymore. We used to use this actually a lot in the NICU. We'd use this, the IV form, to actually try to chemically close a patent ductus arteriosus. If you had a kid who was born that state open end, you could actually use this to try to close it. Again, it goes back to its activity on prostaglandins. Normally, prostaglandins keep that the ductus arteriosus open. We can try to close that. Nowadays, it's moved more to like IV ibuprofen, so we do have some options there. But again, a lot of side effects associated with indomethacin, probably a little bit worse for as far as like GI toxicity than the propionic acid derivatives there. And again, notice as well that the renal effects are still going to be present, right? So things like diuretics are not going to be as effective. Things like your antihypertensives are not going to be as effective, mainly due to the renal effects you're going to see with that, right? Again, better for more short-term sort of use. Now, Toradol or Ketorolac, a lot of people say, but I think the actual proper pronunciation is Ketorolac, but you sound kind of nerdy when you say that, so Toradol works. Very, very good. This is a great parenteral NSAID. A lot of patients, if you go into the ER, you're probably going to get some if you come in with pain. Either IM, IV usage, very, very good, and very opioid sparing. In fact, some people say it works just as well as some of the weaker sort of opioids that are out there, so very good from that standpoint. Not great as an anti-inflammatory necessarily, but black box warning for the GI effects. So you cannot use this for too long, and in fact, most places will limit use to 5 days, no more than 5 days worth. Otherwise, the GI toxicity tends to be more likely. You don't want to do that, right? You don't want to cause a GI ulcer, potentially perforation, etc. And this is important too, because imagine you have a patient who comes in, they got a dose in the ER, and again, you have the ER practitioners who are prescribing that, and they go to surgery, and you have, say, the anesthesiologist who writes for Toradol in the operating room, and then you have some of the hospitalist who's going to be admitting the patient, who's also writing for Toradol orders. Unless you look backwards to see what orders they've already gotten, you may not be able to, you may actually give them too much of this stuff, right? You may put them on an additional 5 days, and they've already gotten almost a day's worth by the time the hospital gets them, right? So again, look back through the chart and see what they've already gotten, see when they got it to make sure you're timing your medications appropriately. And because again, that 5 days for you might be too much for that patient there based off what they've already gotten. That kind of makes sense? Because again, when you have multiple practitioners, you have to make sure you guys are not kind of pulling double duty and make sure everyone knows where they're working at. Anyway. So yeah, Toradol, very good from an IV sort of standpoint. Parenteral NSAID, very good for pain management. Okay, we have tolmetin. This is a better, more oral agent. Again, you may see it occasionally, but good as an anti-analgesic, antipyretic, anti-inflammatory. Probably more potent than aspirin, but it's going to have a little bit more GI problems, a little bit more anticoagulant effects than some of the other NSAIDs we see there. So again, probably not used quite as frequently, but you may see it occasionally. Proxicam is another good one. This has a very long duration of action, so it's good for using less frequent doses throughout the day in order to help manage that kind of more chronic pain there. Again, GI side effects are going to be the biggest thing you see with Proxicam. Now, meloxicam, this is actually a good one for patients with GI, kind of high-risk GI history, because this one actually is a little bit more selective for COX-2 than the other agents we've looked at. All the other ones are going to be non-selective. This one tends to be a little bit more selective for COX-2. So again, if you think about patients like gout or things like that, where you're trying to avoid sort of aggravating any kind of GI issues that patients may have, this is a good one, right? If you don't want to go full bore and use something like a fully COX-2 selective agent, this is a good one kind of in the intermediary there. So meloxicam is very good, long half-life, and good for the GI patients. Right? Nabumetone's another one you may see used occasionally. Again, some COX-2 selectivity, so probably in the same camp with meloxicam there, and used a lot for things like rheumatoid or osteoarthritis, where they're going to be taken kind of more chronically than just like an acute intermittent sort of pain. Next we have diclofenac. This one's good because it actually has a topical formulation that's available. So if anyone's ever seen a Voltaren gel before, what do you think is the benefit of using that? Works very locally, right? So you're not going to see systemic side effects. So again, if I had patients with pain that was very localized to a particular area, it's not very diffuse, instead they have like a GI history or they have a renal history, anything like that, this is good for that. They can just kind of work locally to deal with pain and not have to worry about any kind of systemic effects from that. So very beneficial there. Here it's only available on a prescription basis, but actually if you ever go on a cruise, you go to, say, Nassau, and you go to the pharmacy there, you can get it over the counter. So good for minor aches and pains and sprains and muscle aches and all that kind of good stuff. So if you ever get a chance, pick some up. I don't know if it's technically illegal to carry it across country lines, but we didn't get in trouble, so there you go. Anyway, but yeah, same side effect profile as a lot of the other agents. Some COX-2 selectivity, but not as much as we're going to see with the COX-2 selective agent in just a second here. Okay, so as I mentioned, with COX-2 inhibitors, what's the main draw of using these medications? More selective for COX-2, they're not going to be affecting COX-1 as much, which we know is important for protecting the GI barrier, right? Or keep maintaining that GI barrier. The problem, though, is what we found is that when you used completely COX-2 selective agents, what happened? People died, right? The reason for that is because COX-2 being inducible, it's also important for angiogenesis. Angiogenesis is what? Basically making new blood vessels, right? And so again, these aren't like, big giant coronary vessels they're making. These are like tiny micro vessels, right? They're constantly being made and destroyed as time goes on. What they found was that patients with history of things like stroke or cardiovascular disease, anything like that, they tend to be more likely to develop another stroke, or they had an MI related to this, because basically it's kind of choking off blood supply to those tissues that were more likely to infarct. So because of that, and again, this is one of those things that we didn't really notice until it was used in millions of patients. Because when you think about a phase 3 trial before it goes on the market, how many patients are we treating? Millions? That was like maybe a few thousand, right? So again, if it's a 1 in a million sort of side effect, you don't find out about it until you go to phase 4 trials. And again, who's in a phase 4 trial? Anyone who takes the drug is enrolled in that phase 4 trial, right? And so it's one of those things where we had to take it off the market because of that. And so we had things like Vioxx, which is rofecoxib, and there's another one called valdecoxib that actually got taken off the market because of that, because it was completely COX-2 selective. Very good from a GI standpoint. People thought it was going to be revolutionizing pain management from an NSAID standpoint, but due to the increased risk of death and stroke, they said, no way, we're taking it off the market. So nowadays, all we have left is going to be basically celecoxib or Celebrex as some moderate, it probably has the most COX-2 selectivity, but still not affecting, it still affects COX-1 to some degree, and so you mitigate a lot of that cardiovascular risk. Yes, sir.
Will they still screen patients for like hyperlipidemia or like appear to be a cardiac shape to like prescribe either COX-2 inhibitor?
So again, the only one you have available is going to be celecoxib or Celebrex, right? So that's the most COX-2 selective agent we have, and absolutely, right? So you should be screening for that sort of thing. So if I have a patient who's a high, and again, so basically the studies have not shown that Celebrex is also associated with that increased risk of death. Okay, so basically we think it's still safe for those cardiac patients, but again, if you had to hedge your bets, if I had a really high risk cardiac patient, I probably wouldn't use a selective NSAID on them, right? Because the risk could be there. If I can get away with using a non-selective NSAID, go with it, right? However, if I had a patient with no cardiac history, their heart's totally fine, but they have a high risk GI history, then yeah, that's a really good option for them, right? And what if you have a patient with both, the GI and cardiac history? What could I do? Don't use an NSAID, right? You may be able to get around, hey, just don't use an NSAID altogether. It may just be a bad patient for that, right? And so again, this is one of those things where like every single year, some students always get hung up on this COX-2 selective sort of thing. We see it every single year. I don't know what it is about this particular subject that some people are just like, well, what about this? What about this? It's a lot of gray, right? So again, they're not going to find one single answer that says like, this is what you should do in every single case. You have to take it on a case-by-case basis, right? Because again, all our patients are snowflakes to some degree. They're all going to be a little bit different, but typically they have a high risk GI history of GI ulcers, especially NSAID-induced ulcers. COX-2 selective agents can be much safer for them. If they have cardiac history, I'd probably hedge away from using a COX-2 selective agent. And again, the Celebrex means what we're going to focus on there. Okay. Anyway, we can argue about it in my office if you have any further questions. But again, so mainly you're going to be affecting inflammation, because by affecting COX-2, we said COX-2 is constitutive or inducible. That's inducible, right? So that's what's going to be ramped up during inflammation. That's why it's very good for that, and it limits that GI toxicity there. As I mentioned, the only one we have available is going to be celecoxib. The Ketorolac is sometimes used, but not very commonly. Definitely Celebrex is the most common one you're going to run into out there. Again, looking at the selectivity of it, and again, I said selectivity is all relative, right? So again, even if you had a complete, when you said it's completely COX-2 selective, you have a little bit of COX-1 activity. But looking here on the spectrum here, the one that really had the most, kind of detrimental effects to patients, they're taken off the market. They just saw too much of an increased risk there. The celecoxib has not been shown to have the same risk, and so that's why it's still on the market, right? Does that mean there's no risk? No, it just means we don't have the studies to show that there is a risk, okay? Because again, it's really hard to prove a negative in a lot of those cases there. But a lot of it had to do with things like thromboxane production. A lot of it had to do with things like that angiogenesis, and also as well, like what do NSAIDs do to the blood pressure typically? Due to the kidney effects, usually increases it, right? Because again, if you decrease GFR, what do the kidneys want to do to respond to that? They ramp up the renin-angiotensin system to get the GFR back up. So again, typically they have negative effects on blood pressure. That can put extra stress on the heart, so these are things that could be also kind of playing a role as well. Okay. So that's it for the NSAIDs, the anti-inflammatories. Obviously, corticosteroids we're going to talk about on a more case-by-case basis as we get into things like rheumatoid arthritis, we talked about MS and things like that, those sort of pain conditions. Again, usually on a case-by-case basis, usually going to be more for those kind of flare-ups, right? Because ideally, the dose of corticosteroids you want a patient to be on is 0, right? We just let them produce their own corticosteroids if we can. Okay. But moving into the opioids, the opiates, where does it come from? Anyone know? The poppy plant, right? Because what's kind of the classic thing you think about? Like if you're taking a urine drug screen, say for employment, what do you got to worry about? Eating for breakfast. Poppy seed muffins or bagel or something like that. It takes a lot of poppy seeds. If you show positive, you say poppy seeds, I'm going to have a skeptical eye aimed towards you. But it's possible, right? And again, anytime you have a positive urine drug screen, they usually send it off for confirmatory testing, right? So they'll do a GC mass spec or something and actually figure out what it is. But yeah, this is where a lot of our opioids come from. They're going to be from the poppy plant, right? So how are these working? Well, basically they're working by binding to natural opioid receptors that we have in the body, right? So mainly in the spinal cord, mainly in the brain, where we have a lot of these opioid receptors. They're also located elsewhere. We'll talk about the ones like in the GI tract and things like that. But we have a few different types of opioid receptors we're going to work with. We have a mu, we have a kappa, and a delta. You may see them sometimes called OP1, OP2, and OP3. Same thing, okay? The main one we're going to focus on is going to be the mu opioid receptor, because that's where we see a lot of our analgesic effects. That's where we see a lot of the euphoric effects, and that's also where we're going to see things like the CNS and respiratory effects. So again, no kappa and delta are also important, but not nearly as important as the mu receptor. That's what we're mainly going to focus on here, okay? Again, these are better for more moderate to severe pain. Does anyone know what we get from the poppy plant specifically? We get opium from that, and we get some derivatives from that look very similar to opium. So we have things like codeine, we get morphine. What's the illicit substance you think about when you think about opioids? Heroin, right? Heroin's the other big one, okay? I feel like from certain parts of the country it's a heroin. I used to be addicted to heroin. I just could not get enough of ladies that saved people's lives. It was really bad there for a while, but I got over it. I did that wrong one time. I had a presentation I was giving, and I actually spelled heroin incorrectly. Does heroin have an E or no E on the end? It has no E, and I put a heroin with an E on the end there. Someone's like, oh, really? You're addicted to, a person was addicted to ladies that save lives. And so I said, boy, that's really embarrassing. We'll use that as a joke from now on. Anyway. So yeah, so when you're looking at nociception here, again, you have pain, say located somewhere peripherally in the body, that gets transmitted through these nociceptive fibers here, and it's going to relay here in the spinal cord, right? This is the main site where a lot of our mu receptors are going to be located to cause analgesia. And it's one of those things where basically by inhibiting this transmission here, basically you're going to be inhibiting this firing of those neurons from sending that signal up to the CNS. There's probably some effects here as well. It's kind of a secondary pathway, but the main thing is going to be the spinal cord sort of effects here. And that kind of makes sense, because when you're thinking about analgesia during labor and delivery, what are the patients getting? You guys cover that in OB? They get a local anesthetic, usually get ropivacaine, they also get fentanyl, which is an opioid. It's actually delivered right there into the spinal cord where those opioid receptors live, right? What's the benefit of using like an epidural anesthesia for labor and delivery? It's very localized, right? So again, by shooting for just aiming towards the bottom portion of the spinal cord there, you basically affect the lower half of the body, right? Because again, do you want the patient to be completely numb and totally out of it? No, because they still got to cooperate and try to push, right? So think about little things like that, right? So again, they can actually affect specific opioid receptors based on where we're delivering the drug to, right? That's why positioning is really important for those patients during labor and delivery to make sure it's not getting too high up and causing too big of effects. Anyway, but the main thing here is the mu opioid receptors here in the spinal cord, some of it in the CNS, but mainly in the spinal cord. So basically what they're going to do is try to hyperpolarize those neurons so that that signal, even though it's being transmitted from the site of pain, is going to be sort of inhibited there in the spinal cord and up in the CNS to try to prevent further transmission there. So you may still have the pain there, but you're not going to be quite as aware of it. You're not really so worried about it because the signal's just not making it up there into the CNS. These are also responsible for the analgesia. And then the main dangerous sort of effects here are the respiratory depression and then also the euphoria. Why do we care about the euphoria? Because that can ultimately end up in addiction, right? So that's the thing we're also concerned about with these medications here. Okay, we have kappa and delta. They're also responsible for some effects here. I'm not going to get into the nitty gritty there. Some of them can cause dysphoria. Some of them can be proconvulsive. There's different effects here, but mainly the mu is what we're going to be focusing on. So they all have the same mechanism. You're going to find that all of them are going to be working on the mu receptor as an agonist to cause analgesia and euphoria and all this other stuff. The differences between them, though, you're going to find that some of them can work as maybe a partial agonist, meaning you'll maybe only get a portion of the effect that something like a full agonist would have. Something can be a mixed agonist-antagonist, and then certainly to reverse the effects, we have our antagonists. Okay, and we'll talk about that a little bit later. Most of you probably know about it. It's called naloxone or Narcan, right? So we'll talk about that. Agonists are going to be the ones that most commonly get used. We'll talk about some cases for partial agonists later, but agonists are good because, again, when you're having acute pain, you want to treat that, you want the full effect, right? And that's where you want to have a full agonist. So let's talk a little bit about the terminology here between the different aspects of opioid treatment, which you're going to find. So different points here. So physical dependence. What is physical dependence? Oh, yes, sir.
Kind of like on and off.
Is it going in and out?
Here.
Let me get the microphone. Is that better? Going to stand-up mode? What's the deal with opioids now? Anyway, so what is physical dependence? The body depends on it. Absolutely. Thank you. Just as simple as that, right? So when I say physical dependence, right, that's that your body gets used to having these drugs around, right? Your body gets used to this new normal of having the opioids around. So that means when you take the drug away, what can happen? You're going to have things like withdrawal, just like when you have, say, a patient who's on beta blockers for years, and you take them off a beta blocker cold turkey, what happens to them? Blood pressure spikes up, right? They get a rebound effect. Same thing happens here. The body gets used to having opioids around. You develop a physical dependence. When you take that away, you're going to see withdrawal effects. We'll talk about what those are in a few minutes, but it's an important thing to consider because is every single patient who's on opioid going to develop physical dependence? If they're on it long term? Yes, absolutely. Every single person will become physically dependent. That's just homeostasis. It's just how our body is going to respond to that external pressure, right? The external influence. Absolutely. Now, what is addiction? This is more of a psychological dependence on it. This is where you're going to find that patients, despite no negative consequences, they are still going to seek out that medication, that drug, and get access to it by any means possible, right? So again, when it comes down to, do I only have a certain amount of money available? Do I spend it on food for my kids, or do I spend it on some more oxys? That's addiction, right? You have to make that when you make that decision there. Now, is every patient who's on opioids going to become addicted? No, that is not a guaranteed consequence. Now, what do some patients think? The second you touch the stuff is going to become addictive, right? Because again, you think about heroin users, the first hit, they're always chasing that first hit and becomes addicted the rest of their life. That's not always going to happen with these drugs, right? You absolutely will become physically dependent if you're on it long term. You don't necessarily become addicted. Now, what predisposes someone to addiction or not? Could be family history, so there's genetic components to it, right? Do they have other substance abuse history? Do they have concomitant mental health disorders? Like there's a litany of things that could be affecting this, but not every patient becomes addicted. That's a very important point to note there, okay? Now, what is tolerance? What do you think that is? Well, the effects tend to go away over time, right? So again, you get used to those effects, and that again becomes your new normal. That's your homeostasis now, to where the effects tend to diminish over time. Now, what you will find is that with some effects of opioids, they tend to develop tolerance. You may need to do something to overcome that. So for instance, you get tolerant to the analgesic effects. So what do you need to do to overcome that? You can bump up your dose. So again, remember we talked about tachyphylaxis, how it means you can't increase the dose and you don't get any additional effects. That's not what happens here. By constantly increasing the dose, you will get more analgesic effects here. However, there are certain things you don't get tolerant to. So for instance, like opioids are notorious for causing constipation. They never become tolerant to that. They will always be constipated. They just get more constipated the more you up their dose. So we'll talk about those effects in a little bit, but just know that tolerance is an important aspect of this, and that you can have patients, you have little old grandmas who are probably weigh 80 pounds sopping wet, and they can be on doses of morphine that will kill a horse. Like they can be on massive doses, but their body has developed tolerance over a long period of time. They're very used to that. In fact, there's been some cases where kids, you ever hear like pill parties? Hopefully you guys are kind of in that generation there. You could have been exposed to it potentially. But you guys are all diligently studying and not doing anything like that. But basically, kids would go and they'd raid grandma's pill cabinet. They take a bunch of stuff, and they bring it to a party, and they'll kind of like partake of their medications there. But you know, they think, well, grandma can't be on anything that strong. She's grandma. Now, grandma's probably on some heavy-duty opioids there, and so people died from it because they were taking doses they were naive to, right? So when you talk about opioid-naive patients, what does that mean? They've never been exposed to the drug before. They've had very little exposure to it. It doesn't mean they don't know what opioids are. They're not naive in that sense. They just have never really been exposed to it. Versus opioid-tolerant patients are getting it every single day. They're their body's very well tolerant to the effects. They have that physical dependence in most cases. So something to think about, right? So for instance, I have a patient who comes into the ER complaining of pain. One of the first things you need to ask about is like, well, what have they been on previously? Are they opioid naive? Are they opioid tolerant? So for instance, if I have a sickle cell kid coming in, you guys covered sickle cell before, right? A lot of pain associated with that, and they're on opioids chronically. If I give them 2 milligrams of morphine, they're gonna be laughing in my face, being like, come on, buddy, like give me something stronger. Versus if I give someone who's never been exposed to it 2 milligrams of morphine, they may be pretty well asleep. They feel great. So again, think about that. Think about the doses they've received, and you may see really odd doses and seem astronomical. It could be normal for them, right? Because of that tolerance they've developed over time. Now, what do you think pseudo-addiction is? It's like addiction, but maybe not really addiction. Essentially, it's going to be where a patient maybe exhibiting signs of addiction may not really be addicted. So for instance, imagine you prescribing, say 20 milligrams of oxycodone twice a day for a patient. They've been on it for 6 months, but they're coming back in for, they need a new refill, and it's too soon. Like, you're like, oh, you should have had another week's worth of medications. That could be drug-seeking behavior. That could be signs of addiction. But what else could be happening? What if the patient's pain got worse? Right? What if the patient is now more functional, they're getting around more, and now they're experiencing more pain because of that? They may be showing signs of addiction, but it's not really that addiction there, right? So that's another thing to try to delineate. Now, is it super easy to tell someone who's really addicted and trying to game the system versus someone who has legitimate pain complaints? I wish it was, all right, but it's definitely not, all right? It's one of those big issues there. And again, that's where things like eForce can be really helpful. The prescription drug monitoring program is really helpful to look that stuff up to see, like, okay, well, what's their filling history like? What have they been filling? Are they going to multiple doctors? Are they going to multiple people to try to get their prescriptions? That could be signs of bad things to come, right? So little things to think about. And again, physical dependence will happen to everyone. It's definitely where if you withdraw the medications cold turkey, you're going to get withdrawal, right? And so again, that can be manifested as things like nausea, vomiting, sweating, dysphoria. They're going to feel terrible. They're going to feel like the worst day of their life. They're going to say, oh, I'm going to die from this. Is it fatal? Actually not, right? They're going to wish they were dead probably because they feel so bad, but they're not going to die from this, right? That's going to be in stark contrast, though, if you have someone who's on something like a benzodiazepine chronically and you withdraw that immediately, could that be fatal? Absolutely, right? Because again, you get used to those extra GABA effects, and then you take that away. Guess what? Glutamate takes over. What do you develop? Seizures, right? So you can die from that, right? Just like alcohol withdrawal. Can that be fatal? 100%, right? You have a really chronic alcoholic, go cold turkey. What does that turn into? What's the name for that? Delirium tremens, right? That usually manifests as seizures. That can be fatal, right? Opioid withdrawal, not fatal. Okay, which is important because we'll talk about a big effect of the antagonist when we use that for these patients, because essentially what you're doing is putting them into withdrawal. They're not going to like you for that, as it turns out. But again, it's not necessarily correlated with addiction. Certainly people who are addicted to opioids are going to have some physical dependence as well, but just because they have physical dependence does not mean they're going to get addicted. It's just a normal consequence of being on a medication long term. Happens with antihypertensives, happens with benzodiazepines, happens with any kind of drug. Okay, and actually, when I was writing my presentation for FAPA coming up, one of the big things I saw and kind of ticked off a light bulb in my mind is kind of like, not necessarily looking at patients being high-risk patients, but really they're using high-risk medications, right? And especially when we talk about the side effects here. So again, one of the big things they were looking at is co-prescribing the antagonist for these medications there. And some people feel like, well, you're just giving them license to overdose on these medications. You're giving them license to just go do a bunch of heroin, and they'll have the antagonist and they can do it again. Not necessarily. I mean, if I give someone insulin for diabetes, I gotta give them something in case they get hypoglycemic. Just like if I give someone opioids for their pain, I gotta give them something in case they get too much of it on an accident, right? So again, look at high-risk medications, not necessarily high-risk patients. This is something I've been kind of thinking about. Anyway, weird tangents, but as I mentioned, with addiction, this is something where, again, despite the negative consequences, they're still having to get that medication. Again, if you have physical dependence and you start to withdraw, it's going to appear like you have addiction, right? Because you need to get access to that medication to kind of get you back to normal. But typically here you're going to find this is a very compulsive sort of use. Despite that obvious harm, they're still using the medications. And again, you're going to find that by hook or crook, they're going to find a way to get their medications. And that's actually one of the big things we've seen. So has anyone ever heard of the Oxy Express? So Oxy, when I say Oxy, what does that refer to? Oxycodone. It's a very, very potent, very popular opioid to abuse. And the Oxy Express was basically, Florida's kind of the originating spot of the Oxy Express. And basically, you'd have people by the busloads who come down from places like West Virginia and Kentucky. They come down here and they go to these pill mills. I say pill mill, what does that mean? You have these prescribers who are giving out illegitimate prescriptions for hundreds and hundreds of these pills that these patients would then pick up. They'd fill it at potentially kind of pharmacies that were in cahoots with the providers, and then they would take it back up by the busload, back up to West Virginia, Kentucky, and other places, right? And then they can disseminate it out, right, as a means to make money. And so it was a big problem here in Florida for a good long time. And so when I was in fellowship, back before the pill mills really got shut down, what we saw was a lot of prescription opioid abuse because it was cheap and it was easy to get access to. Okay. Well, eventually, like in 2011 or 12 or so, we started to really crack down on those places. A lot of people went to jail. A lot of these places got shut down. And so what do you think people did? Oxy started to get more expensive. May not have had the money for it. What do you go to? Heroin, right? So now we're having a heroin epidemic in Florida. There's a lot more deaths associated with heroin because, again, that's what is available. That's what is cheap, and they can get access to it. and then all kinds of problems with heroin that we'll talk about at a later date. But for our purposes here, just know that this is something where really, despite those negative consequences, they're going to find some way to get access to the medication. That's that component of addiction there, right? Anyway, as I mentioned, tolerance, you will definitely get tolerant to the analgesic effects, but you typically do not get tolerant to a lot of the side effects, right? So for instance, constipation is always going to be there, right? You're still always at risk for things like respiratory depression associated with this. But imagine, like, if you have someone who, say for instance, is a truck driver for a living, right? You typically want them to be of sound mind when they're driving. Does that mean they can't ever be on an opioid for chronic pain? Well, no, like you tell them initially, like, hey, be careful whenever you're operating heavy machinery or something because your mind may be impaired, but eventually you get tolerant to those effects, right? So you can have patients who are on massive doses of opioids that are acting just like normal mental status, talking to you like a normal person, right? So again, that impairment tends to go away with time. You get tolerant to some of those effects, but some things you just don't get tolerant to. And as I mentioned, a pseudotolerance is usually going to be a change in pain state that causes the patient to kind of manifest as addiction sort of like symptoms there. Okay. And again, don't confuse a pseudo addiction with addiction. Very difficult though to really ascertain whether or not the patient has legitimate complaints or it's illegitimate. So again, sometimes you have to use your clinical gestalt, right, to try to determine like, okay, what's going on with this patient. Okay. And again, looking at whether it's addiction or appropriate use, one of the things you can kind of look for is what is their change in function, right? So again, is the patient becoming more functional, right? Are they able to go back to work? Are they able to do the things they like to do in life? That typically is more signs of actually adequate pain management, right? Versus addiction, they typically tend to lose function, right? So they lost their job recently because they're, too zonked out on their medications to actually go in. Things like that could be signs of addiction and kind of give you some idea of whether it's maybe appropriate use or not, as the case may be. But again, just know physical dependence is absolutely expected with long-term opioid therapy. It's going to happen 100% of the time. Incidence of addiction, though, can vary widely based on the population, depends on the genetics, not going to be guaranteed with every single patient. Okay, and again, E-Force is our system we have to go and look this stuff up. I probably told you the story about the adult patient who was in the peds ER for complaining of kidney stones. She was getting her second round of Dilaudid in the peds ER, and I was like, this looks a little fishy. Something was tingling my spidey sense, and I was like, something's fishy here. So I said, let me look up the E-Force. Looked it up, and sure enough, the person had been filling under various addresses and dates of birth and all kinds of things all over the state, been filling hundreds and hundreds of oxycodone. So I go to the provider and I say, hey, look at this. And again, it's nice because you can print this stuff out and go to the patient and be like, look at this. Can you explain any of this? And I showed it to the provider, and he's like, oh, I can't believe it. I thought the pain was real. She seemed like she was in so much pain. I said, well, they can be really good actors. Like they can really learn to fake this stuff. People will, prick their fingers and put blood into the urinalysis, so that way it looks like they're actually having legit kidney stones. Like they can do these things, right? Because that addiction will cause them to, by hook or crook, like they're going to find some way to get their medications, and that was that person's way of doing so, right? So again, and at that point, the provider's like, well, now that I have this evidence, I'm not going to give her anything. And that's that, right? So again, sometimes that can be really helpful when you have objective evidence. It's like, hey, here's what the history is. Can you explain it, or can you talk to me about it? And lead you to say, well, I'm going to give you something or potentially not, right? Because again, you can say, hey, you just filled 100 oxycodone yesterday. Why are you in the ER saying you're out of meds? Hard to argue with that, right? Anyway, so that leads us to House Bill 21. Now again, have PAs in Florida been able to prescribe narcotics for very long? Like 2017, right? So again, it's a relatively new thing. You guys will never have worked without that ability. But a lot of people did for a good long time, right? That's why I talk about some meds that we PAs and nurse practitioners would use for a while that were non-controls, but you could use it for things like sleep, like trazodone and things like that. But now you do have that ability, right? So you're going to be subject to the same law here. And so this is a big feature of my talk that I'll be giving. But basically, it went to an effect in July 2018. And does anyone know what some of the big effects were with it? For one thing, you have to look up the prescription drug monitoring program before you prescribe those narcotics, right? And when I say narcotic, that really refers to anything that's a controlled substance, right? Whether it be C2, 3, 4, or 5. Now, most of the opioids you're going to be prescribing are what class? Well, it's going to be C2, right? They have the highest abuse potential. They still have a medical use, right? Because C1 is what? C1, no acceptable medical use, right? Cannabis still technically falls in that category. Heroin falls in that category. Methamphetamine falls in that category. C2 means they have a high abuse potential, but there is acceptable medical use. So amphetamine, dexmethylphenidate, and ADHD fall under C2. Oxycodone, morphine, fentanyl, hydromorphone are all going to be C2s. Okay, so again, high amount of scrutiny placed on those prescriptions there. But you have to check the PDMP before you prescribe. That's mandated now, okay? Now again, a lot of the computerized systems are building that into where it automatically will come up for you, which is very handy. But if not, you can go to that eForce page. And again, how do you find it? I can give you a link, but what's the easier way to do it? Google it, right? Just Google eForce, Google PDMP Florida, whatever, and it'll take you to the page, right? And so again, you as a healthcare provider, once you get your license, can register for it, and then you can start to look this stuff up. Does that mean you can look up like your boyfriend or girlfriend? No, right? So again, use some common sense here. Don't look up patients you're not taking care of, but you could look up anyone technically in the state of Florida. So you have to look at that. The other big thing that changed was how much of these opioids you could prescribe. Okay, so for acute pain, you now have a 3-day limit you're going to be writing for. Okay, so it means you can give 3 days worth of medication on that prescription. Okay. Now, if you want to do any longer than that, you can extend it up to 7 days by writing on the script acute pain exemption. Actually, I probably should have put one. I should give you a prescription assignment where we have to write that on there. But so that's for acute pain issues. So if they come to the ER complaining of pain, most patients are only going to get a 3-day supply. Unless you write acute pain exemption, they can give out up to 7-day supply. Now, does that mean there's a absolute pill amount that I'm allowed to write for? No, actually, you can write for something crazy. You can say like, let's do Dilaudid 4 milligrams every 2 hours for 3 days. The pharmacist is probably still going to call you like, this is a little crazy. What are you doing, right? However, 3 days worth is going to be the limit there for most prescriptions, up to 7. Now, if it's for, say, a chronic pain patient, this is where you have to actually write for non-acute pain, and then you can write for up to, say, 30 days worth, right? That's going to be for more patients that have legitimate chronic pain issues. Again, this is more probably going to be, not necessarily you're going to be doing this necessarily. A lot of times you're probably going to be more focused on the acute pain issues. But if you work in like a pain management clinic or something, it may be more likely to see those kind of chronic pain patients, right? So anyway, and again, I gave you some examples of C1 substance. Again, there's no acceptable medical use for those. What are some other examples of C2s? Yeah, a lot of our pain meds. So again, most of our opioid pain medications are going to fall in that category. Anyone know what hydrocodone used to be? It used to be a C3, which means it had a lot of scrutiny with it, but we saw so much abuse with it, now we bumped it up to a C2. So now most of those opioid analgesics happen to be C2s. What's another example of a C2? Cocaine is actually a C2, right? There's an acceptable medical use. So when you're studying really hard and you're just falling asleep, and you don't do that. So your amphetamines are for. But there's some ENT procedure where you can actually use cocaine. It's a very good vasoconstrictive anesthetic sort of agent there, right? And whenever watch older crime shows where they were testing to see if cocaine's real or not, and they rub it on their gums, anyone knows what they do that for? Yeah, if it makes your mouth numb, you know it's cocaine because it's an anesthetic. A little bit of tidbit of information you didn't know before, right? But anyway, again, just know there's an acceptable medical use. Normally, you're going to have a lot less, you're going to have more restrictions on a C2 as far as what you can write for. So again, when looking at this, you're going to only be able to write for up to 90 days worth for a C2, potentially. Typically, you're just going to do 1 month at a time, though, so just 30 days at a time. But a lot of restrictions associated with those. Can I call in a C2 to a pharmacy? Have to be on paper, right? They have to have you on a tamper evident paper. Again, there are some means to try to do some electronic prescribing that are changing, but I can't just call it in, right? 3 through 5s, potentially I could do that. So again, just know there's some restrictions there. So I got about 10 minutes left. Let me cover a couple of these and I'll check the board here. So first off, let's start with the kind of the wimpiest of the bunch. We got codeine. I've talked about codeine before. What does codeine get turned into? Morphine. Actually, codeine gets turned into morphine. That's actually the active component of it, right? And so typically, when you see Tylenol number 3, just know that is referring to acetaminophen plus codeine. Again, it's one of those cases there where you see a lot of acetaminophen in conjunction with the opioids because it provides some synergy there as far as analgesia goes. The codeine is actually metabolized through CYP2D6 over to morphine. So what would happen if I had, say, too much CYP2D6, that are very active, ultra-rapid metabolizing CYP2D6? What could happen? I'd have way too much morphine being produced, and I could see too much of an effect. I can see a toxicity that can develop. We'll go over the toxicities a little bit later, but we had some people dying from that actually, right? So again, this is those cases where for pediatrics, you never use codeine anymore because what was happening is we had these kids who were getting, they're coming in for obstructive sleep apnea. We give them a TNA, the airway's all swollen, and you give them this codeine. Some of the rapid metabolizers would make a ton of morphine from it, and then they have respiratory depression. They die from it. So we actually don't use codeine anymore in pediatrics. You still may see it used occasionally for older patients, but definitely falling out of favor because of that CYP2D6 issue. Well, what happened if I had, say, poor metabolizing CYP2D6? I'm not forming much morphine, then what's going to happen to my analgesia? It's not very effective, right? So in those cases, you can find that some patients, when they don't respond to a medication, some of it could be related to how they're metabolizing it. I'll show you a few more examples of that, but this is the most prominent one, right? So just know CYP2D6 metabolism, rapid metabolizers, more likely to see toxicity and good analgesic effects. Slow metabolizers, less likely to see analgesia. Less likely to have toxic effects, but it's not going to be all that effective for them as an analgesic, right? Okay. What do you think the benefit of writing for codeine is if I could just give morphine? It's better for more like kind of mild to moderate sorts of pains, and also it's less restrictive. So it's either a C3 or a C5 depending on the concentration, but it could be useful if you did not want to write for like a C2 potentially. You can get around it that way, right? Anyway, so things to know that. So less potent than morphine, more mild to moderate pain, as I mentioned, either C3 or C5. And this is actually a new black box warning on these, so you have to be really careful. And again, can you look at a patient and tell if they're a CYP2D6 ultra rapid metabolizer or not? No, there's certain ancestral sort of linkages here for certain patients, but again, for the most part, we just don't really know, and so it's better just not use it at all for the most part. But you still will see it occasionally. Okay, so morphine, or morphine, as some people like to call it. It's a kind of a workhorse sort of analgesic. It's been around for forever, right? So if you ever look at the like kind of old timey like prescription bottles, like from the snake oil salesman, like you see a lot of things like heroin and morphine and a lot of like over the counter products. It's a wild time back in the 1800s, but anyway, there's a lot of different forms that are out there. So we have IV available for sure. So again, very common when used in the hospital. You also have PO routes, and they can either be IR or ER. Now say IR, what does that mean? Immediate release, and then ER means extended release, okay? So what do you think is better for kind of chronic basal sort of pain throughout the day? Extended release products, and then IR is better for breakthrough pain, right? So you may see a patient who's on 2 different forms of morphine, and that can be therapeutically appropriate. If they're on, say, morphine extended release twice a day to cover their basal pain 24/7, and then they have a PRN immediate release morphine for breakthrough pain, and that makes sense, right? So it would say PRN for breakthrough pain. You could write that on the prescription, and that would be therapeutically appropriate. If you ever saw someone who was on an extended release product, PRN, that is inappropriate. They should never be on an as needed extended release product, because what would happen, do you think? They build up too much, right? So they end up dose stacking, where it's like, oh, I got pain, I'm going to go ahead and take an ER product. And then, oh, I'm still got pain 2 hours later, what am I going to do? Take another one, and another one. And then they end up dose stacking, the levels get way, way too high, very likely have toxicity. Because again, if you look at the actual kind of the drug profile here, if you were to look, and again, wonderful drawing here, but if you were to look at, say, for instance, the concentration over time, what do you think an extended release product would look like? Kind of a long sort of plateau, right? It kind of a slow meandering increase and then decrease over the dosing interval there, versus an immediate release product would look like what? Big peaks, right? Big peaks and then big valleys. So that's why you use it for that breakthrough pain. It's good for that acute sort of pain, to acutely deal with that, and then it dissipates. So again, that's why it's good for as needed breakthrough pain versus the extended release products are better for that kind of basal, kind of constantly there sort of pain. Okay, so that's a big difference. Yes, ma'am.
So since this one's not metabolized by the CYP, say they had the rapid metabolizer and the other one, could you put them on this if you really had to?
Yeah, you're much safer putting them on just straight morphine rather than codeine, because again, you get more predictable response out of it, because you don't have to worry about it getting converted to the active product essentially. 100%. Very good. Now, it's to note that you still have to worry about metabolism, but in here you actually have to worry about things like not getting good renal metabolism, because there are some active metabolites. When I say active metabolites, what does that mean? Yeah, the metabolic byproducts are still causing effects, right? Whether they be toxic or positive effects. And so, for instance, we have patients who build up morphine 3-glucuronide as a byproduct, and actually causes hyperalgesia. What does that mean? More sensitive to pain, right? So actually you can find patients you're chronically treated for pain, they may actually become more sensitive to it. It may seem like, well, man, I keep giving them more morphine, but it's not working. Could be related to the metabolites are not clearing very well, right? Another one we have, and this actually one builds up a lot in older patients who have poor renal function, this is morphine 6-glucuronide. And this actually has greater analgesic properties than morphine itself. So that means if you have poor renal function, you're not clearing that morphine 6-glucuronide, they get higher levels, which may be good for their pain, but it could also mean a bad thing, in regards to their toxicity, right? More likely to see that respiratory, CNS depression. So they're all things you have to kind of balance out for those patients. And again, I would not recommend this for like elderly patients with poor renal function. Morphine's probably not a great agent for them in the long term, right? Good for acute management, but not good for chronic pain management, okay? The other big thing to note with morphine is a lot of people say, oh, I have a morphine allergy. Morphine allergies are typically not legitimate because what they're really getting is a histamine release. So a lot of patients will complain of nausea, vomiting, they'll complain of itching, they'll complain of rash. Most of that's related to histamine. How could I treat that if I saw that in a patient? Give them Benadryl, I give them an antihistamine, right? So when you ask about a morphine allergy, see what reaction they actually had, because that will actually dictate which medications they can get. Because you're going to find, oh yes sir.
If you're giving Benadryl and morphine at the same time, you like over-sedate your patient.
100%, thank you. Yes, so that's a very important pharmacodynamic reaction where by combining the sedative effects of antihistamine plus the sedative effects of morphine, you can get patients who's too sedate, right? Now, normally antihistamines don't cause respiratory depression, but when you start to combine different sedative medications together like this, you can find synergistic effects on those effects as well, right? So again, they're more likely to see that CNS depression, more likely to see that respiratory depression, than get themselves into trouble. So absolutely, that's an issue. However, if I'm not really worried about my patient being too sleepy, may not have to worry about it so much, right? Again, if they're coming in for a painful femur fracture, they want to sleep it off a little bit, that's probably okay, right? As long as they're still breathing. We'll talk about monitoring a little bit later on, right? A lot of these patients, you don't necessarily need them awake, right? You just want them to be comfortable for the most part. But anyway, so again, be careful with that. Just know that that's related to histamine. It's not a true allergy. And because we'll talk about structural similarities between other opioids that are out there, and that by saying a morphine allergy, that kind of cuts you off from a lot of different opioids, and you don't want to necessarily cut yourself off if you don't have to. Okay, so something to keep in mind. Okay, so any questions before I check the board real quick? Nothing else. Okay, next time we'll continue on with more opioid talk.